certainly within the last few days, the Community Guide to Preventive Services endorsing, after a systematic review, the positive impact that community health workers can have working kind of between the space of, say, public health and medical care, specifically to improve cardiovascular health. So I hope folks will take that into heart and really think about that, since it's a brand new recommendation based on the latest. I think they looked at 31 or 32 studies in that area. So that you know, CMS doesn't have the tendency of prescribing exactly how you do it. It's that it be done. And I mean, I think if you think about that, you don't want CMS prescribing that, because these solutions really are local, and they need to be local because the healthcare system and the population actually varies so much from one locale to another.
So how does the community plug in to give info, like to CMS? To
this particular model, or in general?
In general.
Well, the community stakeholders and consumer advocates are really part of every, whether it's a request for proposal, request for comments. They are very vocal at a wide variety, and I wasn't involved in the design of this, but I would be willing to wager a little bit of money on the fact that consumer advocates were actually at the table when this was designed. So there's lots of different ways to include that perspective. All right, thank you so much for your time, and I'll turn it back over, I guess, to Jose. Or
I think Alan.
Alan.
So we have such a multi-talented group here. Watch this, Dr. Erdl.
No. So I have the great pleasure of introducing Stefan Schwarzfelder, who's a German national, now an American, here with Palo Alto Medical Foundation. I think they're very lucky to have him because he's a project manager in process improvement and has a very, very deep background, which I will try to provide for you. So he did his studies first at the Bildungszentrum für Gesundheit und Pflegeberufe in Lahr. So that's in Baden-Württemberg. So very beautiful area. It's about 50 kilometers north of Freiburg, which is the gateway to the Schwarzwald. He's a Schwarzwälder, so a person from the Schwarzwald. Then he went and did his master's at Universität Trier, and that's on the Mosel River. So this is one of the most beautiful wine-growing regions of Germany. So it's in far western Germany, about 50 kilometers from Luxembourg, and I spent some time on the Mosel, in 2007. He has his project management professional certificate as well, and he's been with the Palo Alto. I'm coming down with a little bit of a cold. So. My German isn't as good as it should be. And so he's been with them for about 4 years. Palo Alto Medical Foundation for 4 years.
Almost, yeah, 5.
5 years, okay. And is the quality and patient safety nurse specialist and program manager. And he's very data-driven. We got to talk about that a little bit. He previously was with Google for about 6 months. And then he spent a long time, 5 years, I think, with the Federal Institute for Occupational Safety and Health for Germany, and developed a number of publications for them, including Guide to Prevention of Occupational Health and Safety Risks in Healthcare Sector. So, and that was translated into how many languages?
22.
22 languages. So he was a lead on that. So, and he's also been a data management consultant for Deutsche Telekom, and he has written a very interesting book based on his thesis regarding the role of the loss and development of wisdom. So that's what he's here to impart wisdom for us. So, herzlichen Willkommen.
Thank you, Dr. for the great introduction. It made me actually kind of smile. Yeah, so a little bit more to my person. So I'm working closely with our medical director for quality, Dr. Ed Yu. Some of you might know him. And usually he's presenting our organizations in events like this. And this time he asked me if I could present, and I was thinking, well, what can I tell you that he couldn't tell you better? And I think one advantage to have me here today, or try to give that advantage, is that I will show you a bit more the nuts and bolts of the program we kind of like running on a daily basis. So I try to give you a little bit more insight into the pieces in our system we have set up. A piece that I cannot talk about too much is what our providers do to work with their patients. That's our providers piece. But I can show you what we show them and kind of like how we highlight that something needs to be done. Let me just figure out how I can scroll here. So the Public Medical Foundation is part of the Sutter family, Sutter Health. We have about almost 1 million active patients. In terms of our outreach that I am kind of working on, and I'm the program manager for, is 250,000 patients. That's our P4P population, HMO population, and also our shared savings agreement. For some of our measures, we're extending that to kind of like all of our patients. So that's always like the target that we kind of like, we start in a certain patient population and try to extend it to all of our patients if possible. And we just started doing that for our blood pressure patients. We have about 1,400 physicians, 45% primary care, and some 55 specialties, around 4,500 employees. You see around 35 locations in the Bay Area. Some more statistics here, 46 clinical departments, and our patient population is 25% HMO and 75% fee-for-service. So the first question I want to ask you, and I want to encourage you to ask me questions too during the presentation. I would very much like to have that kind of like a dialogue between us. I prefer that over me just having a monologue and presenting to you. So ask me questions, whatever interests you. One challenge I observe in my work, and I have to say we're doing really well on quality metrics, but still quality has always to compete with other priorities in our organization. And I assume you might be in similar shoes. So some examples you see here is like patient access, cost reduction is always a topic for us. We all want to grow, increase our patient volume. We have a lot of organizational change. I assume you have similar situations where different groups grow together. Patient satisfaction is very important to all of us. Accreditation comes around every so often. And so those are all those different priorities that pull on our leaders and our care teams and make it sometimes hard to have like a continuous program for quality in place. So it brings us to our first question where we can use our voting buttons. I don't really know how that works. I've never used it before. I would ask you, do you feel sometimes that quality metrics are not a priority at your organization?
I think you have to go to the next slide.
Maybe the next slide?
Yeah.
It's open.
Perfect.
And I was told I'm supposed to wait until we have about, that's very sensitive, sorry, about 41 responses.
Already 41?
No, I'm waiting.
Okay, now it says up there in the top that 5 people have used the clicker so far, so if you would...
I have to open it
all of
somehow.
you-
I accidentally closed it.
Does everybody have a clicker? So we've got about half of people have responded. Give them a few more seconds. Since we're not seeing any movement, we'll just go ahead and tabulate.
This one? I'll just do it. So here are your results. So it's always a priority of 13%, sometimes 47%.
Always not a priority.
I think there's not a fusion.
Huh?
So the question is not a priority.
Oh, let me go back. What was the question here? you sometimes are not a priority. Yeah, so it's not a priority in your organization.
Yeah, always not a priority.
That makes the question difficult. It was not an intentional trap here.
It's a board question.
I have to make an assumption here. I assume you understood the question in the way that it's always a priority, sometimes, rarely, or never. Correct me if I get this wrong. So I would read the graph like this, like for 30% of you, it's all quality metrics always a priority. For sometimes 47, rarely 28, and never 13%.
No, I think it's the opposite.
It's the opposite?
Well, because of the not.
Okay, so I should have worded the question differently.
If you get the idea that only about half the time,
Yeah. Yeah, you have the center, just flip it around. So let's summarize that about half the time. It's a priority, other times it's not. Any thoughts if you see those results in your end? Does it need to be a priority all the time?
Yes.
For my daily work, and my world is all about quality metrics, so I'm a little bit like, I have a blinded view, I don't have to serve the other priorities, but I serve quality. But from my point of view, if we want to be successful, that's my mantra always, we have to do it every day. So if I see departments and divisions that explain to me, like we have other priorities right now, and you work on something else, like I understand, but I want to let you know, if you wait for 3 to 4 months until you focus again on quality outreach, you're going to be behind. And you won't be able to catch up anymore. And when you look at the end, at variation between different departments and different divisions, and we have a lot of variation in our organization between different departments. The departments that do well, the divisions that do well, have a system in place where they do it all the time.
it's that 13%, which is why you have only 2 groups in California that have ever gotten our Platinum Award, and one of them is presenting today.
If I could just kind of be a little provocative, I think what I hear a lot from physicians and other clinicians is that they actually feel their organization, that quality metrics are a top priority. They're not always so certain that quality itself is. And I think that disconnect that's perceived between what we can measure and what we know and can recognize as true quality, we still don't quite have the metrics.
And I live with a daily dissonance myself, because like my target is that we achieve our targets. So we make the P90 on all of those metrics, but is it always the best patient care? So I have to settle to that, sometimes say, we do what's best for our patients, and we don't cater to the metric.
Right. Yeah. But sometimes it's really about the measurement tool and getting the data and gathering the data. So I think the key issue is sometimes you have to put significant resources into the process so you can capture that data. It's not always easily to capture, and because a lot of clinical data is sometimes not not within a a specific sort of graph or a way to capture that data. You run into some issues, and so now you got to get the resources to put it in, and now you're talking about money, and that's where you prioritize. So when we talk about metrics, it's really about the ability to measure.
And I think I'm fortunate that I work for a large organization that has resources to do that, because like what we'll be talking about in the next slide is a lot about the system we put in place.
Well, and it gets to this point that I was thinking with Dr. Thompson. If I make my doctors go put that data in themselves and plug that stuff in, they're going to hate me. If I can figure out a way to calculate this in MOS and do it for them, they're much more likely to help reduce the risk factors and do the work that they're supposed to do rather than just focus on the metric itself.
So I just want to say that the Right Care Initiative focuses on, the key proxy measures of how well the Department of Managed Health Care feels we feel that these 3 metrics, with the help of all of our academic partners, are good proxies, to use use Dr. Ertle's word, of whether or not the care is being proactively managed. So is that diabetic's blood sugar in good control? Is the hypertensive blood pressure in good control? Is the heart patient's cholesterol in good control? This is indicative of, is there proactive care management going on? And that's why we focus here, in addition to the fact that if those things aren't happening, those patients are at undue risk for heart attacks, strokes, amputations, blindness, disability, and death. And that's why we're all gathered here for 3 years in a row, because we all love this stuff. And thank you, Stefan. We can go on with your presentation.
Thank you. So we're going to our next question. Are you alone in your work on quality metrics, or do you feel part of being a team of like many people being involved and working together? So to read out the question for you, how often do you feel that you are part of a group that strives to collaboratively achieve joint quality targets? And looking at this setting, I would assume most of you say yes, we are part of a group. I would be interested in your responses. Yes. And I hope I do not have a nod over here this time.
So all of you who voted, next time let's vote more quickly.
No pressure. So that's good. 59% of you feel being part of a group all the time, and 41 sometimes. So none of you doesn't feel part of a group. And that's a big part of the system I'm talking about, and I can go over this a bit more quickly if I'm kind of like trying to open doors here, and you already kind of work in a team. But a big part of our success is that there is like a big team behind the work we are doing. So it's not something somebody can do alone. And on the picture here you see our data analysts. So we have an analytic team that provides us with data, which is the basis for our work, that we have like reports on our patients, that we have dashboards, that we know how we're doing. You see different of our associate medical directors, which are our key champions for different divisions, and they have a crucial role and as a leader for quality, go to the different divisions and different sites and pass to the care teams how they are doing on the different metrics and if they have any obstacles and find ways to improve together.
So walk around management.
Yeah. And we also have two patient representatives in the group that give us helpful feedback, what's important from the patient perspective, that we don't lose it out of sight. Because sometimes we tend to overcomplicate things and think in our own world, and I think you might want to word that question a little bit differently because I really understand what you're asking. I'm in more detail, and I'm not going to go too deep, but an important piece, especially for the divisions, and I included here Dr. Dickedaldi, he's the president of our Santa Cruz division in this, because he has a crucial role for this division by being continuously, every day, like a leader that asks how we're doing about quality metrics. And this is like about the importance. So we have Gemba walks. I don't know if you're all familiar with Gemba walks. It means that you go to that the leaders go to where the work is actually being done. So that decisions are not only made in meetings. So you go to the front care staff on a frequent basis. Usually they have monthly meetings. They have a visual display where they show how they're doing in the different areas. It's not just quality, there's also patient satisfaction, access. So they focus on different topics. And then they ask, are we on track for our targets? Do you encounter any obstacles, and how can we help you to overcome those obstacles? But it's a really important part that we have that leadership support, because if they would not go out and say this is really important to us, we wouldn't have the results. And you also see like local leadership it's in the same, so it just shows like how many different people are involved. Those are our different social medical directors. I mentioned those in the slide before. They have a key role of communicating quality metrics and to explain what needs to be done. We have a process, for example, in place where they go out every month. We have like provider education one-pager, so we select one metric we want to endorse and explain, and we explain it on one page, and they go out to the teams and say like, let's talk about this metric. And you can imagine over time, like if you talk about every month about a different metric, you can go through a lot of metrics, and you can also repeat the process at a point if we need further education. I'm not going to go too much into detail, but we were fortunate enough that we received some awards in 2014, and this helps us to keep us on track because everybody's happy when they're doing well, and it provides like a lot of momentum to keep you going. I just want to mention what I'm not going to talk about it too much today, but I didn't want to have it overlooked. So we have a lot of processes in place for disease management, clinical guidelines, or continuing education that I'm not directly involved in. Being part of a big organization is that you have your piece of the pie, but there's much, much more that contributes to the success. And if you see, for example, at the bottom left, the EMR disease management protocol, so I think it's important for our success too that we have in our electronic medical records that if you have a diagnosis for diabetes, that you have automatically like listed in your health maintenance section that you need an influenza vaccine, pneumococcal vaccine, you need lipid screening, like hemoglobin and microalbumin. So the moment the provider says like diagnosis diabetes, you have those tests on your health maintenance. And it also means like if you have a health maintenance, they will receive again notifications from us too, that the patients are due, and the patient will receive a letter from us and follow-up phone calls if they don't come in, reminders that they're due for those screenings.
Can I just see by a show of hands how many of the medical groups and plans do those kind of reminder letters and outreach calls?
Half. So that's a big part of my work, and all the people I'm working with is this outreach, to be kind of reaching out to our patients. And then also what we try more and more to do is in-reach. So when patients come to us, that we use the opportunity. And this is something where we have also still a lot of room to improve. Patients come to us, they even go to our labs and get certain labs done, but not all the labs. So we try to tell our care teams, look for the next upcoming appointment and try to use the opportunity to get other screenings or lab work done as well.
I have a question I want to ask you. What if the patient is pre-diabetic? You know, they have to potentially become full-blown.
Yeah.
They're managing their healthcare through, through diet and not using medication. Do you have a protocol for that? Just
in the process, like I'm talking about right now, it would require a diagnosis for diabetes. So the pre-diabetes would be, it's still in the management from the provider would manage that, but it's not part of that process. So I'm just going to go through a few steps that kind of describe our system. The first one is like priorities and targets. So everybody needs a vision. So the vision of our medical director is to be the #1 medical group in quality outcomes in the nation. It's a pretty modest target goal, I think. Well, we all have to strive to do better, and I think it's good to have a high target in a way that we always try to do better. So like even if we achieve our targets, I just recently had a conversation with our managed care department, our health plans, and they were asking us, so you missed some patients, how can you do better? And then we started talking, and after a while, Dr. Yu reminded us, just to make it clear, we achieved our target. So what we're talking about is like the patients that are beyond the target, so what can we even do better to reach even more? Just to put it in perspective, it's not that we kind of like performed really badly. Because you felt kind of bad, like, oh gosh, we missed all these patients, like what did we do? And it's hard, especially to get close to 100%, you encounter many challenges. We have a large number of quality metrics, and here we come to our next one. Yeah, please, next question.
Like when you measure that to get better, do you go back and see maybe what's the group that was left out, or is it a youth group? Is it, an ethnic group? Do you go back to see how you can do better?
Yeah.
That way?
Well, we do usually like a root cause analysis. So we look at what would be the cause that we didn't do well. So for example, like currently I'm working on a metric like the proportion of days covered. So like if you are on a statin, that you take the medication 80% of the time of that measurement period. And one thing we're doing is then we start by asking providers to give us an explanation. Why do you think that this patient didn't take his or her medication 80% of the time? And then we collect, or I send out a survey, and then with multiple answers, and just try to get like some kind of evidence, like what is the most likely reason that we kind of missed that group. So just briefly, like we have a lot of quality metrics. So first step, this is a challenge for me because like I always like to address as much as possible, and I feel bad to say like we're not going to work on a certain part. But what I learned too is if we send out too many asks, too many quality metrics out to our care teams, they're just simply overwhelmed. It's too much. They can't do it all. You have to break it down to them. And even within your priorities for the year, you have to break it down again. During the year, this month you're focusing on this one piece, next month on another piece. Once they're doing better, they're more and more able to take on more. That's my experience. The really high performers, they really have a system set up that they don't really need reminders on a lot of the measures. And they can say like, okay, what else can we focus on? So my next question to you would be, how many metrics do you think is our medical foundation accountable for in 2015? And then this includes outpatient and inpatient care. And we go to the next one, and I have to reset that now. I know I understand the system. I think I missed something. One more. I can thank you in your name for the really fast response.
Thanks, everybody.
So let's see. We have like 13% over 50, 35 for over 150, 33. So 68% say over. Let me break it down. 33% say like over 250, and 20% like over 350. So answer C is the correct one. It's like over 250 metrics. So having said that, it does not mean that we kind of like can work on those 250, or actually I think it's 267 quality metrics, and they also overlap. Some metrics overlap, but the challenge also is that the different metrics, even if they sound like the same, often have different measure specifications depending who's asking about the measure. So one piece of our work is like to simplify. And I have to remind our medical director always remind to keep it simple, keep it simple, keep it simple. And so we try to find like a definition that kind of like includes as many different metrics as possible and is in the best interest of our patients. So in the first step, we always follow guidelines, and then we say like, well, let's see which metric is fitting to the guideline, and then is that also like, does it also fit to the other metrics? So we try to simplify. So overall, we have like, this year we have 28 quality metrics on our satellite dashboard. Those are the metrics we are focusing on out of those 267 quality metrics. And part of that dashboard are also the Right Care Initiative measures. So we have the blood pressure control, We have the lipids, LDL under 100, and control blood sugar, and for cardiovascular and for diabetic patients. So it was beneficial for us that all those metrics are part of the agreed upon focus area for 1 year.
So, Stefan, for your 140 over 90, I know that the IHA did change their metric for the 60 and above to 150 over 90. So you guys are still at 140 over 90 as far as
For diabetic patients,
diabetic.
it's 140 over 90.
So you have a different metric for regular adults, or you're pursuing that at all?
We basically follow the same GNC8 guideline. I just looked at the
Exactly.
public card, it's exactly the same. I don't know if all of our providers go all the steps down, like to the whole card, but the beginning, the first third.
Most patients don't need to call.
So a big piece of what I want to talk about is like visibility of care gaps. So here a quote from Edward Deming. I don't know if you're all familiar with Dr. Deming. He did a lot of work on control charts, SPC charts. So it's not just enough to know, not enough to do your best, you must know what to do and then do your best. And that's something I feel like we have to repeat in our work over and over. Not just like what is our target, but what do you need to do to get there. Often there's an assumption, I've been in many meetings where we said, let's provide a report and everybody knows what they need to do. That's not my experience. So you actually need to explain to them what do they need to do, what can be done. There's a little personal story, so making gaps visible. This is my kitchen. That's my remodeling project from the last weekend. And as you can see, it's not completed. My wife had let the project at least complete by the end of the week, but at least I left the kitchen semi-clean. You see my cat at the bottom exploring and evaluating my work. So I included this because in our daily life, our gaps are really easily visible. When I go into my kitchen, I'm reminded immediately, okay, this is not done. And I'm motivated to complete it, or I get in trouble at home. And in our quality work, our care gaps are often not visible. So often we don't even know how we're doing. Providers don't know how many, because they look at one patient at a time, they don't know all the time, like how am I doing across all of my patients, and how many percent are out of control, or who are the patients I haven't seen yet this year. And just for you, I was like those before and after. That was like how the kitchen looked before. So, here's my next question to you. Do your care teams know during the year how they're performing on blood pressure, A1C, and LDL metrics, and which patients are measured non-compliant?
So throughout the year, not at the IHA P4P annual,
Anytime,
the year.
anytime during the year. I think I need you continuous assistance with
give
this.
them a little bit of time.
You're setting it?